Hello and welcome to MRSI Talks ART, the latest advances of IVF. I am Dr. Angie Beltsos, founder and executive chair of the Midwest Reproductive Symposium International, MRSI. Our podcast is dedicated to experts providing single subject exploration into advances in IVF. Thank you, Ferring Pharmaceuticals, for your continued commitment to education by sponsoring this podcast. With us today are two phenomenally talented doctors. Dr. Zaraq Kahn is double board certified in OBGYN and REI with past practice designation in minimally invasive surgery. Dr. Kahn completed his residency in OBGYN at the Mayo Clinic. He completed an NIH-funded master's in clinical research and then went on to start his first fellowship in REI, also at the Mayo Clinic in Rochester, Minnesota. He was awarded the prestigious Mayo Clinic Scholar, which allowed him to complete a second traveling fellowship in minimally invasive gynecologic surgery, reproductive organ transplantation, and endometriosis excision surgery. Dr. Kahn is also the co-program director for the annual MRSI Symposium. Joining Dr. Kahn is Dr. Rahi Victory, Fellow of the Royal College of Surgeons of Canada, Fellow of the American Congress of OBGYN. The namesake of our practice, Dr. Victory, is a board-certified obstetrician, gynecologist, and infertility specialist dedicated to helping improve the reproductive health of men and women. Dr. Victory also serves on the MRSI Content Program Committee. Welcome to you both. Dr. Kahn will explore the role of reproductive surgery in modern treatment of infertility, isthmocele, endometriosis, adenomyosis, robotics, and more.
I am incredibly excited today to have the honor and the privilege of interviewing and speaking with Dr. Zaraq Kahn, a very unique reproductive endocrinologist, because he is not only board certified in reproductive endocrinology and infertility, but also has a subspecialty in doing minimally invasive gynecologic surgery. And we are very, very excited and honored to have you here today. So thank you so much for joining us.
Good morning, Rahi. I'm so excited to be here, and it's a privilege and honor to talk with you this morning.
I love the fact that we are very likely going to become fast friends because we have the same philosophy about reproductive endocrinology, and that is in regards to the importance of reproductive surgery, which, in my opinion, has really kind of died off in a lot of ways from the REI world and has really kind of separated itself into a niche of being MIG surgery, and then the REIs are doing the REI. And, you know, it's really rare now to see someone like you who is able to do both. What kind of drove you to do that? What was the deciding factor?
Yeah, that's a great question. And I'm so excited that we share a common passion of reproductive surgery. It's all started in residency. I went to residency at the Mayo Clinic, where I currently work as faculty. Pretty GYN surgery heavy residency, sort of really inspired me to do a lot of surgery. But then, of course, my passion lied in reproductive medicine. Classically, when you look at the pioneers of reproductive endocrinology and infertility, they were doing the entire gamut of REI, which includes not only infertility and IVF, but reproductive endocrine and reproductive surgery.
Right.
And really, it was the reproductive surgeons that sort of laid the foundation for minimally invasive surgery and advanced pelvic surgery that we're currently doing in a lot of MIG scenarios and reproductive surgery scenarios. So when I was in training, unfortunately, the pendulum had already shifted, and there was more emphasis on infertility and IVF because that was an advancement. So I had made a commitment to myself to commit to more training, and of course, doing another fellowship in minimally invasive GYN surgery. The ultimate goal was really for that to be that bridge between these two sort of advancing divisions now, which is MIGS and REI. Because at the end of the day, it's the patient really wants continuity of care. And so what we do in our day-to-day practice is taking that patient from the GYN clinic through surgery into the REI clinic, through fertility treatments, and then to a pregnancy onwards to OB. It's that entire journey that's so fun to do and take with patients. And honestly, it's now because I do mostly endometriosis and the entire sort of facet of endometriosis care, these patients are coming back after their 3 or 4 babies for their hysterectomies for adenomyosis or penultimate treatment for their disease process. So it's really fun to sort of walk this patient through their entire reproductive sort of lifespan, which is very rewarding at the same time.
Absolutely. And I think, again, that it's so critical that we have reproductive surgeons specifically because of the fact that when you, with your history of at least having the REI training, are doing surgery, undoubtedly you're thinking more about preservation. You're not going to do something to the ovary where you're going to compromise ovarian function. I know many of my gynecologic colleagues will happily take bipolar cautery to the ovary. I remember in residency, when they would take out a cyst, they take the bipolar and start burning the ovary. And now when I'm teaching residents, because I'm a fertility specialist and I still do all my own minimally invasive, I'm constantly telling them, like, don't cauterize the ovary. Please don't cauterize the ovary, right? So, you leave it and it'll just contract. And that's missing from a lot of surgeons now because they maybe aren't either aware of that or their focus isn't on the preservation of the fertility. It's just let's get rid of the cyst or let's, restore the anatomy or let's solve the pain problem. But they're not thinking, is this going to impact the patient's fertility later on down the line?
You're absolutely right. And I think, I have the privilege to teach both REI as well as MIGS fellows. And really, when we're in the room, we're always talking about, okay, we need to do this the REI way or the MIGS way. There is slight subtle differences, even something as simple as a salpingectomy, right? And I mean, when we are taking the tube out, in the MIGS world, we're really trying to just get the pathology removed. But in the REI world, we're trying to save all those arcadial mesosalpingeal vessels that can still contribute towards the ovarian reserve, and you're trying to be very careful around the vasculature of the uterovarian ligaments. And there's some subtleties that we do, point in case adnexal or ovarian surgery is so important to avoid cautery or electrocautery in that area. What cysts to remove, what not to remove. And especially in the world of endometriosis, right? Like we have a lot of now data about like what areas we can do uterine conservation maneuvers where you can even excise and remove disease from the uterus with uterine sparing techniques. Adenomyosis, where patients have been given no other option but a hysterectomy. That's when the reproductive surgeons can really come in and really help with uterine sparing procedures. And also, I think we have that extra toolkit of like thinking beyond surgery, because as REIs, we're dealing with alternatives to surgery as well. Fibroids, for a case an example, augmenting sort of surgical techniques with uterine artery embolizations and also MR-guided focused ultrasound surgery. I mean, there are various things one can do to really sort of save a uterus that otherwise has a lot of pathology and still give that patient sort of that chance for fertility with advanced fertility treatments, right? And so that is when what we do becomes so rewarding, is where the patient has been given the similar answer of hysterectomy or we've got to remove this pathology. And if you can do that conservative surgery in certain scenarios, it is really helpful. And another area really is the endometriosis, where patients are never given or only given a choice choose between pain and fertility. And why would they choose between one or the other? They want relief of both and they want treatments for both. And I think that's where a lot of our expertise can really help as well.
I couldn't agree with you more. And one of the problems I find, and we've kind of developed a real process for this and I guess a reputation for this, is that when we focus on endometriosis for fertility patients, we have a very holistic approach to it. And so we don't tell people to just endlessly go back and do more IVF, because by surgically intervening, you can actually optimize their care. It shouldn't have to take 3, 4, 5 rounds of IVF. If you get the embryos and then you treat the disease, you can actually improve their chances. And there's pretty reasonable data on that, showing that it supports the process. But what I hear from a lot of the fertility clinics, or at least through the patients, is no, they told me endometriosis doesn't matter. And I'm just like, oh my God, how can they be saying this, right? Endometriosis, of course it matters. There's a brilliant study that compared outcomes, which I'm sure you're familiar with, for women that took egg donor eggs for their IVF cycles. And they compared the outcomes for the women that had endometriosis versus those that didn't. So obviously there's no impact from, the embryo standpoint because it's never seen endometriosis. It's never been exposed to the endo. And they showed it was almost a 50% reduction in success. So off the hop that there's no question that the endo is going to make a huge difference in outcomes. But unfortunately, because we have this huge divide between the surgery and the REIs now, you can't get that kind of integration for people to understand it does make a difference. We can optimize for people. We can do better.
You're absolutely right. I mean, that's our day to day, right? When we see patients like after sixth or seventh failed embryo transfer, and you do imaging and they're full of endometriosis or they have adenomyosis that's never been addressed or even talked about.
Right.
And it's an unfortunate scenario, but we can definitely help. I mean, we just wrapped up data or our experience of 9 years at Mayo that we're publishing, but really truly showing that even if you have advanced disease, just by optimizing the pelvis, excising all the disease, and then allowing the patient to get pregnant, you can even get up to 30% spontaneous pregnancy rates. Now, what was interesting was the literature even says 20%. Honestly, I've always doubted that. But when you look at your own data, numbers don't lie. And I think the 30% is really because we've ruled out adenomyosis as well, right? Because adeno and endo go hand in hand. And in the literature, we are unable to distinguish those two. So really, both those things matter a lot. Now, of course, we know that IVF and ART is exceedingly important for these patients with really poor fertility outcomes, especially those with advanced endometriosis and diminished ovarian reserve. And our data would show that, at least in our data, we are showing that 70% are still going to need IVF with advanced endo even after excision. So it's really, the question becomes really, one is not more important than the other. They're both equally important, and we need both advanced excision surgeries and techniques, and also advanced ART and IVF to really help these patients with poor prognosis. And really, when you're combining those two, we're looking at cumulative pregnancy rates of more than 85% with patients with advanced endometriosis, which is kind of unheard of. And it really is exciting to see that. And it's really exciting to see that the pendulum is swinging back towards really talking about that, especially with newer data now coming from Europe, talking about bowel disease and excising that disease being so important for fertility as well. And if you really think about it, it makes physiologic sense, right? It all comes down to inflammation and inflammatory processes.
Right.
If you have just a category 5 hurricane of inflammation going on in the pelvis, how is that pelvis going to be receptive for a pregnancy, really?
Yeah, absolutely. It's not. And the inflammation is so important. And the more we learn about endo, the more we understand that it has so many impacts on other things. So it's not just that you're dealing with endo. There's this huge ripple effect from everything. One thing you mentioned begs the question, of course, and this is central to the whole debate about the role of reproductive surgery, especially for endo cases. It's the chicken or the egg question. So do you do the surgery first and see how the patient does, or do you make your embryos first and then do the surgery? And before you answer, I'll give you my opinion here. I think it varies case by case, but as a general rule, there's reasonable evidence that endo gets worsened by doing IVF. So if you have an endometrioma, if you've got deep infiltrating endometriosis, you're probably not going to improve it by doing multiple rounds of IVF. So I generally tell my patients to do their IVF if they need it and make their embryos first and then go for the surgery. But I'm very keen to hear what your view is on this.
That's the $1 million question, right? And whenever I get asked that question, I always joke and say, that's my job security, because it's a completely individualized approach, right? So I'll give you an example. If I see a 34-year-old, and let's say the imaging is similar, a 34-year-old with bilateral endometriomas, a 4 centimeter and a 8 centimeter, and her ovarian reserve is AMH is 4.0. And she has never had children. She's open to IVF. She's not open to IVF, never had kids. Young, robust ovarian reserve, same disease.
Sure.
Then I have a 39-year-old, same disease, 4 and 7 centimeter endometriomas, AMH of 0.8, and she may be open to ART. Very different approaches. So for the advanced patient with that adnexal disease, of course, ovarian surgery is going to reduce her AMH even further, and I may compromise the IVF response. So we really want to get that IVF done and get those eggs retrieved if possible, pending, of course, if you can retrieve around the endometrioma safely and things like that. But we really want to try our best to try and get a stim done for patients with really bad ovarian reserve and adnexal disease, because that's going to worsen after surgery.
Yeah.
Whereas the younger patient, we may do surgery for her, and we may actually not need ART for this young patient. If her tubes look good, and in a heterosexual couple, if the sperm looks good, after disease excision, we might actually give her 3 to 6 months of trial on her own. And, again, our data would show that those younger patients under 35, overall cohort, about 30% will get spontaneously pregnant without adeno.
Right.
But under 35, we're looking at about a 50% pregnancy rate spontaneously even.
Wow.
So it's really interesting to sort of like make that decision call on a case-by-case basis. And in my opinion, the age, ovarian reserve, size and number of endometriomas, and then also the ability or desire to do IVF are some of the really important factors that one has to really balance and counterbalance while making that decision. Yeah. And of course, it's an individualized decision based with, after talking with the patient too. But that's what makes what we do super fun. Because you can, because sometimes the neuro residents always say, well, why did we do IVF here first? And why did we take this one to surgery? And it's interesting, after like 3 or 4 months, they start to understand why and start to make that own critical decision making. But no two patients are made the same, is what I say. Right. And so it's so individualized. Hence, again, the plea of having people like us that have both a fertility and a surgical background to sort of put those two hats together in that critical decision making.
Yeah. And I think, to be honest with you, we're a very rare group now. I mean, there aren't a lot of us that even believe in having both, abilities. I think everybody has just gone to this toolbox of IVF cures everything, and IVF doesn't cure everything, obviously. Right. And so I think people have either given up or lost the ability to think surgically. And so they just keep telling people come back over and over again, when in reality, there is a lot we can do on the surgical end. And I say this all the time to patients and on social media. I mean, I think anyone can really do IVF. It's not rocket science. I could probably teach pretty much anybody to do an egg retrieval and learn a protocol, and you can do a decent cycle of IVF. But my personal victories, my own kind of pride and joy, is when I do them surgically, because not everybody can do the surgery. And I think there's a lot more finesse, and the fact that you facilitate it happening naturally is wonderful for the patients, not just from a cost savings perspective, but like they want it to be natural. There's no one that walks in the door saying like, I want to do IVF. This is always my dream, right? So I love it when we do it surgically, because you get to sometimes, like you just said, eliminate the need for doing the IVF procedures. Now, I do want to ask you, do you have a cutoff for when you will or will not take out an endometrioma? So let's say somebody already has their embryos. They've made 5, 6 good euploid embryos. They're ready to go. They're frozen. And then they find out after all these stims that they've now got a 3 centimeter or a 4 centimeter endometrioma. Do you recommend to them that before they start transferring, they do the endometriosis? Or do you say, why don't you try 1 or 2 first?
Yeah, that's a great question. I think that's really the area where we're lacking a lot of evidence. And so, there is, ESHRE talks about, the European guidelines really talk about an endometrioma about 4 centimeters or greater, but then they're talking about it in the context of egg retrieval.
Yes.
And this is what makes this so interesting, right? Because even the answer would be different even if you change the question subtly. So the question really that you posed was that this person has embryos, 7, 8 good quality embryos. They have about a 3 centimeter endometrioma. So then I think the conversation comes down to, does this patient have pain? Because if this patient has pain, no question, I'm addressing the endometrioma and I'm excising endometriosis prior to embryo transfer.
Sure.
If this patient is completely asymptomatic, I might decide to talk to the patient about a long-term suppression protocol, so about 8 weeks of letrozole and Lupron suppression, and then going in with an embryo transfer, because there is some European data that does show that if there is disease that's macroscopic in the pelvis, but you're not able to address it because the patient doesn't want surgery or has had multiple surgeries or things like that, you could enhance their fertility and embryo transfer rates by going into a suppression protocol for about 8 weeks prior to transfer. But if this is a small endometrioma, the patient is completely asymptomatic, we might try an embryo transfer or two if she has 8 embryos. Now, also then in the context of how many embryos does this patient have, right? If the patient has 1 or 2 embryos, I might be more aggressive and actually excise and remove even the littlest and smallest of disease, compared to a patient that has more embryos. Then we may have to have that conversation of saying, we can avoid surgery because I know you want to get pregnant, you don't have pain. Let's try 1 or 2 embryo transfers and see if you got pregnant. Great, you avoided a surgery. We'll think about the endometrioma later or afterwards. And so that's what, in my opinion, makes what we do so much fun, because just in that one question, I gave you 3 or 4 what ifs and an if this and if that scenario. And really, it comes down to really talking with the patient as well and what their goals and desires are. And I think that's fair game when there is lack of good evidence to really use that clinical judgment and that basically conversation with the patient to see what is going to be best for them in that case scenario.
Yeah, absolutely. Now, do you feel that a reproductive surgeon should be attached to every fertility clinic? Like, should patients have to go elsewhere to achieve that? Or should fertility clinics start kind of creating their model to include that as part of the care services that they provide?
Well, first of all, I love that you asked that question. Secondly, I'm also surprised that you asked that question because you know my answer. I'm exceedingly biased as a reproductive surgeon. I think there's immense, immense benefit of having a fertility surgeon in infertility practice. I can give you just an example of our practice at Mayo. We have 2 fertility surgeons, and we're integrated into the entire practice. I actually chair the division of REI, and we still do IVF. I still do IVF 1 day a week because we have a rotational system, and I still make the decisions or the clinical decisions on the IVF cycle on my patients. But it is when my colleagues come in and ask questions about their patients, it's so important. This patient now, when we sit at 1 p.m. and make clinical decisions on IVF and their surgical questions, we're right there. So it's like a curbside consult for all my colleagues' patients. Now, imagine this patient is getting a reproductive surgeon consult just within 5 minutes informally in an IVF meeting behind the scenes. And if they need surgery, they're in my clinic next week. And if they don't need surgery, they continue to do IVF. Compared to if this was a clinic without a reproductive surgeon, then they don't even know if they need surgery or not. So this patient is referred out to the MIGS group, which will take another 2 or 3 months to get in. Then they make the decision if they're doing surgery, that's another 4 months out. Then they do surgery and come back in. So by the time their patient is coming back into the cycle, it's 6 to 12 months. And as we know, currency in a fertility clinic is time. Right. And so you are really saving patients 6 to 12 months in general for just a simple question. Not just that, I mean, of course, patient care is at the top of the pyramid, but then also sort of continuous learning for our colleagues. Like my colleagues that are doing IVF only, I can bet you know more about reproductive surgery than probably most MIGS providers because they're living and breathing and they're in those meetings every single day. And then, of course, we also talk about sort of the clinic and the benefit to the clinic. You're generating more revenue, you're keeping surgery in-house, you're really providing seamless care for that patient under one roof. So I think it's one of those rare scenarios where it's a symbiotic win-win on all fronts of care, from the patient to the provider to the clinic and the administrative staff. So I clearly am biased, but like I have nothing to say but good things about having reproductive surgeons, and I think we're learning from that because if you look at care across America and in these big IVF centers, it's not uncommon to see reproductive surgeons now who get triaged all the surgical care from the clinic, and that surgery is done seamlessly under that one clinic, and patients are transferred back to their fertility providers. So
Right.
it's much easier for the patient at the end of the day.
Now, I'm going to push you just a little further on this one and ask, do you think in the future we're going to have sort of REs and then reproductive surgeons, or do you think we can drive reproductive surgery back into the realm of this is under the scope of what an RE should be able to do?
That's an excellent question. I think that our present, unfortunately, is that we have REs and people that do surgery, call it reproductive surgeons or MIG specialists. I do think the future is different, and I think brighter for reproductive surgery. We have really, the past 5 years, we've started the SRS SSD, which is the Society of Reproductive Surgeons Surgical Scholar track within an REI fellowship that's approved by ASRM. And really what it is taking a fellow through 3 years of REI fellowship, but because our research requirements have gone down, it's 18 months clinical now and sort of a year of research. So they get an extra 6 months of just surgery. They have their main thesis in surgery, and they start doing more surgery. They have minimum case requirements that are akin to most RF mixed fellowships, actually, that they're doing from year one onwards. So we're really training fellows within the REI fellowship and giving them that additional training of minimally invasive surgery. Actually, the second reproductive surgeon in my group that is extremely busy and robust is one of our first SRS SST graduates.
Oh, wow, that's great.
And so it's really fun to see that come full circle. We have 13 programs approved now for this throughout the country, nationwide, and lots more applications coming in. And so it's really an exciting time, I think, that we're living in right now, because we're really seeing that upsurge of reproductive surgery, even in ASRM circles and the fertility circles, which is very exciting to watch.
That's amazing. And do you feel when you're assembling this structure with the RE clinic and the reproductive surgeon or MIG specialist, I mean, it takes kind of a team, a multidisciplinary approach to this, right? So, and you touched on that earlier. So do you think it's mainly the RE and the surgeon, or do you think, like, do you take an even more holistic approach? Are you guys introducing naturopaths and nutrition? Because you go online and you see there's like endo dietitians and there's endo naturopaths and there's, now they have like endometriosis doulas. Like, I mean, it's kind of endless because people are realizing this is really important and it affects so many women. So how big a model do you think we need to create to optimize the care experience for patients?
Yeah, great question. I think that when we think about just endometriosis in specific, because that's a disease that's really prevalent across both the RE and the reproductive surgery world, of course, it's an entire team. We have basically our team at Mayo is comprised of the chronic pelvic pain clinic team, the pelvic floor physical therapy team, a nutritionist, the cognitive behavioral therapy team, so the psychologists, the surgeons, and then we even have a team that does hormone replacement, so the women's health clinic that just deals with hormone replacement. And then, of course, in surgery, I always tell people endometriosis is a team sport. So I know you and I are aware of this, but for the audience, really, endometriosis can impact multiple organ systems. And there are times when you do surgery. I'll tell you, this Monday, I was in surgery for 12 hours in a patient where it was myself, a urologist, a colorectal surgeon, and a cardiothoracic surgeon. Because we had endometriosis in the upper abdomen, in the chest, in the pericardium, in the bladder, in the bowel, in the ureters, and of course in adnexa in the uterus. This patient still got a minimally invasive surgery. This patient still went home the next day, and this patient still has embryos frozen and will be ready for an embryo transfer soon in 8 weeks. But it took a village of surgeons to really take care of this patient, and truly, it's such a I'm a lifelong learner. I think we're all nerds to some to some extent when we're in these fields.
Yeah.
And so really, I mean, I could tell you I was a kid in a candy store when we were looking at the pericardial excision and like I was asking questions and now I know sort of what to do if I'm in trouble. And so it just like scratches every itch of curiosity and lifelong learning. But also at the end, how impactful for the patient. I mean, this is a patient that was otherwise going to have 3 or 4 different surgeries that can just have a one-stop shop and come out sort of
Yeah,
disease-free.
it's incredible. Well, listen, this has been incredibly informative. I love the fact that I finally found someone who is absolutely aligned with my own beliefs. So this is amazing, great synergy. And I can't thank you enough for honoring us with this incredible opportunity to learn from you today. If people want to contact you specifically to learn more about the fellowship program or about reproductive surgery, how should they go about getting a hold of you?
Absolutely. Happy to get any email. It's my last name, Khan, Khan, dot first name, Zaraq, Zaraq, at Mayo, Mayo.edu. And thank you so much for this wonderful conversation. It's just been an honor to talk with you, and I'm so excited to make a new friend, and I can't wait to grab you at one of the next meetings and really talk all things endo and reproductive surgery, because as you know, there are very few of us, and it's so exciting to find friends that have similar passions for reproductive surgery.
Absolutely. We will meet up at MRSI and we'll do a dinner together for sure. It'll be a great opportunity. Thank you again for joining us today.
Thank you so much.
Dr. Kahn and Dr. Victory, we thank you for a compelling presentation. Thank you. If you want to hear more from Dr. Kahn and Dr. Victory, join us at the 2026 MRSI in Full Bloom Annual Conference, July 26th through the 29th, 2026 at the Drake in Chicago. In the meantime, join us in May on MRSI Talks ART, the latest advances in IVF, and our vision to bring the world more babies by being a beacon of change, inspiring curiosity, pushing boundaries, advancing science, and uniting minds.